Next up is mesothelioma, which is a disease of the pleura, although it's also been diagnosed as a disease of the peritoneum. Do you recall the related exposure for mesothelioma? Asbestos. Of course, the risk is multiplied with cigarette smoking. It's characterized by pleural plaques, thickening, and effusions, and has a very high mortality rate. Now this is a chest x-ray of a 67-year-old man exposed to asbestos 40 years ago. What do you see? You can see large pleural-based masses in the right lower lung, with loss of right lung volume likely due to scarring or atelectasis. Here's another plain radiograph for the same patient, this time from a sagittal view. In this image we can see large pleural-based masses in the right lower lung. Now on histology you'll see pneumoma bodies, which are laminated calcifications. Now this image happens to be examples of pneumoma bodies from a meningioma. Can you remember what endocrine malignancy of the head and neck also has pneumoma bodies on histology? That would be papillary thyroid carcinoma, the most common malignancy of the thyroid. Check out our endocrine section for more on that. Pancoast tumor is a classic type of lung cancer situated in the apex of the lung. Here's an example of a Pancoast tumor that can be seen in the right upper lobe of this chest x-ray. These are typically non-small cell lung cancers. Can you remember where small cell cancers typically arise in the lung? Correct. Small cell cancers tend to be centrally located. Remember, the S for small is also S for central, sort of. You can also get Horner syndrome through compression of the cervical sympathetic plexus. And what's the triad of Horner syndrome? Well, that would be ptosis, anhidrosis, and meiosis, from loss of the sympathetics to that side of the face. Now, what structure is affected if you also get pain and weakness in that arm and hand? That's the brachial plexus. You can also get hoarseness if the recurrent laryngeal nerve is involved. Now, what other structure might be obstructed? The superior vena cava, which brings us to superior vena cava syndrome. SVC syndrome is a result of venous congestion of blood coming back to the heart from the head and neck. You can see the lung cancer of this chest x-ray, which is compressing the SVC. So what would you expect to see clinically? Well, since you're blocking venous return from the upper part of the body, you can see facial swelling, as well as JVD, and upper extremity swelling. You can also get shortness of breath, headache, dizziness, and rarely cerebral edema, aneurysm, or a brain bleed. Now here's a picture of a patient with SVC syndrome. On the left, he has facial swelling in the early morning, which is resolved by the time the picture was taken on the right later in the day. You can see the fullness of the face compared to what his face looks like at night. SVC syndrome most commonly occurs in the elderly population secondary to bronchogenic carcinoma. Now, if you saw this in a younger individual, what would you think? Well, you may think of lymphoma or leukemia, or possibly some infectious process like tuberculosis. Thrombosis can also be a cause secondary to any type of coagulopathy, or maybe a central venous foreign body like a catheter, pacemaker, or guide wire. Now this condition is a medical emergency because of an increased intracranial pressure, possibly leading to a brain bleed. Treatment choices include steroids, diuretics, endovascular shunts, as well as surgery, radiation, and chemotherapy directed towards the lesion. Let's move on to lung cancer. Now lung cancer remains the leading cause of cancer death among both men and women. Suffice it to say it's pretty high yield for step 1, so go ahead and put a big star next to this slide. Lung cancer may clinically present with cough, hemoptysis, and so forth, or it may show up as an incidental finding on chest x-ray or chest CT. Metastasis to the lung is the most common malignancy you'll find in the lung, and will commonly present as multiple lesions. Now this is a common theme in terms of cancer metastasis, and that'll be discussed further in your hem-onc chapters. If a primary cancer metastasizes, it will show up as multiple lesions, usually in a vascular distribution. Now, mets are typically coming from primary tumors in the breast, colon, prostate, and bladder. On the other hand, when primary lung cancer metastasizes, it most frequently goes to the adrenals, the brain, the bone, and the liver. The complications and sequelae of lung cancer are pretty high yield, and the Sphere mnemonic does a pretty good job of summarizing them. They include superior vena cava syndrome, Pancoast tumor, Horner syndrome, endocrine paraneoplastic effects, recurrent laryngeal symptoms, and effusions. Now, other than these conditions causing their own set of problems, why is it important to know these complications? Well, it's important because they're often the first signs and symptoms of lung cancer. Let's see if you remember the classic triad of Horner syndrome. Correct. Ptosis, meiosis, and anhidrosis. So if someone comes in having these symptoms in addition to a cough, you want to think about some sort of lung mass that's compressing the cervical sympathetic chain. Okay, let's talk about different lung cancer types. As we go through the various lung cancers, keep in mind their typical location in the lung, whether or not they're associated with smoking, and their associated symptoms and histologic characteristics. Adenocarcinoma makes up about half of all primary lung cancers, so it's the most common one out there. It usually occurs in the periphery of the lung tissue, often at sites of prior injury or scarring. Now, what mutations should you expect in this cancer? KRAS, EGFR, and ALK mutations. If you examine the fingers, what might you find? Clubbing, also known as hypertrophic osteoarthropathy. On histology of adenocarcinoma, you'll notice the involvement of chlorocells and/or type II pneumocytes. Fortunately, if you catch this form of cancer early, it can be surgically resected. Now, bronchial alveolar subtype is much less common and is not related to smoking. It typically spreads along the alveolar walls, appearing as thickening of the walls. Flash quiz. What are the sequelae of lung cancer? Well, that's our sphere mnemonic: superior vena cava syndrome, Pancoast tumor, Horner syndrome, endocrine paraneoplastic effects, recurrent laryngeal symptoms, and effusions. Squamous cell carcinoma has clearly been linked to smoking. Now, how does it present? Well, it presents as a centrally located hilar mass arising from the bronchus. Hypercalcemia of malignancy may be seen with squamous cell carcinoma due to the production of parathyroid hormone-related peptide. Recall from the endocrine and musculoskeletal chapters how PTH stimulates osteoclast activity, thus releasing calcium from the bone. Histologically, you're looking for keratin pearls and intercellular bridges. Now, can you see them on this image? Well, in the right box is a keratin pearl, and in the left box are prominent intercellular bridges, almost like tram tracks throughout the image. Of the common primary lung cancers, this would be one of the better ones to have because it's resectable if you catch it early enough and has a relatively good 5-year prognosis. Now, on the other hand, small cell or oat cell carcinoma is an extremely aggressive, poorly differentiated cancer. Small cell carcinoma is a centrally occurring lung cancer. It can produce excess ACTH or ADH and cause different paraneoplastic syndromes. Now think for a moment how these might clinically show up. With excess ACTH, you may have excess cortisol release. Now, can you think of a very commonly tested endocrine disorder that involves excess cortisol levels? Correct, Cushing syndrome. While excess ADH in the absence of normal stimuli, also known as the syndrome of inappropriate ADH, leads to fluid retention and hyponatremia, or a low serum sodium in a patient with a normal volume status. Do you remember the name of the syndrome associated with antibodies to presynaptic calcium channels? Well, that's Lambert-Eaton syndrome, which you learned about in the musculoskeletal section. Now, what's the hallmark presentation of Lambert-Eaton syndrome? Well, the classic presentation is a patient with proximal muscle weakness. On histology, you note the chaotic or undifferentiated quality of this lung cancer. Here's another example of a histopic. The small dark blue staining cells are the neuroendocrine Kolchitsky cells, which can lead to some of the paraneoplastic symptoms we just discussed. Now, what genetic aberration might you expect in this situation? Amplification of the MYC oncogene. Now, this type of cancer is not resectable. Why do you think that is? Well, it's because metastasis occurs very, very early on. Think of small cell cancer being too small for the surgeons to see, so it can't be taken out of the body intraoperatively. It can be treated with chemotherapy, but as I mentioned, it has the worst 5-year prognosis among the major lung cancer types. Large cell carcinoma tends to be peripherally located. This type of lung cancer also has a very poor prognosis compared with the other non-small cell lung cancers. It's not really responsive to chemotherapy, and resection works only about half the time. On histology, note the large, undifferentiated cells called pleomorphic giant cells, thus leading to the name large cell carcinoma. Flash quiz. What do keratin pearls in a lung mass suggest? Squamous cell carcinoma. Now, carcinoid tumor is an interesting but uncommon lung cancer that carries a fairly good prognosis, which makes it a perfect testing topic for step 1. This typically presents as a bronchial obstruction with coughing or hemoptysis. If you were to biopsy the mass, histologically you might see carcinoid cells in the classic rosette patterns seen here. Now, occasionally it can also present as carcinoid syndrome. Now, what kind of symptoms does carcinoid syndrome present with? Flushing, diarrhea, and wheezing, due to the production of what hormone? Correct, serotonin. You can also get fibrosis of the tricuspid and pulmonary valves from high levels of serotonin, which can lead to right heart failure. So, here's a related board question. If you have someone who presents with carcinoid syndrome, what else would you be looking for outside of findings specific to the lung? Well, carcinoid tumors more commonly occur in the small bowel and appendix. However, you usually don't see carcinoid syndrome unless it metastasizes to the liver. Now, why do you suppose that is? Because the substances released by the carcinoid tumor in those locations are typically metabolized and inactivated by the liver. Now, getting back to the lung, the good news is that this type of tumor tends to be slow-growing and does not metastasize frequently. This is mainly treated by surgical resection, and the 5-year survival rate is really good, 75 to 95%, compared with the other lung cancers. Overall, how can you remember which of these lung cancers are central versus peripheral? Well, like we talked about, one way to remember this is to remember with the S sound. Squamous cell and small cell are both central. A 35-year-old man comes to the clinic complaining of increasing exertional dyspnea. The patient denies productive cough or fever. On examination, a nodular liver edge is palpated. X-ray of the chest reveals an increased anterior-posterior diameter, a flattened diaphragm, and increased lung field lucency. The patient is a non-smoker and has no occupational hazards. What mechanism is responsible for this disease? The answer is C, misfolding of a protease inhibitor protein. Now, this is alpha-1 antitrypsin deficiency. It's a genetic disorder that leads to both cirrhosis and emphysema. The enzyme is normally responsible for inactivating elastase, which is a protease present in the lung parenchyma. The molecular basis is a mutation that causes misfolding of AAT. Consequently, AAT cannot be effectively released from the hepatocytes, and this is deficient in the rest of the body. This results in overactive elastase within the lung, which destroys the alveoli, resulting in emphysema. Although smokers also develop emphysema from destruction of the alveoli, in smokers it tends to be centriacinar, whereas in alpha-1 antitrypsin deficiency, it produces a panacinar emphysema. Alright guys, well that's all for respiratory pathology. I'll see you next time.